In the way and to come here to be in person for a live stream event, which I know is a bit vital. Come in. So before we get started, I'll just give you a little rundown. First of all, let me thank Marinisha, who's going to give an introduction to Professor Graves, and my old student Rhea, who's at the back there, who will feel really impossible to invite Joe. And thanks to Wharton College as well for sponsoring the drinks and snacks afterwards. We're going to get started, and then I think the talk will go on for about 45 minutes, and then we'll have plenty of time for questions. So do get engaged. This is an opportunity not to be missed. And then at about 6 o'clock or so we can finish. We are recording, so please bear that in mind. But what that means is that the recording will go onto the YouTube channel for the Evolutionary Medicine seminar series. And if anyone needs to loo, it's that way. Okay. Thanks very much.
Brilliant. Thank you so much, Paula. Good afternoon, everyone. How is everyone doing? Great the elements to be here. It's fabulous to see you all. And it's a wonderful privilege to have this opportunity to introduce Professor Joe Graves and also the talk that he will be giving. A little bit about myself. I'm Marinisha. I'm Director of Medical Ethics and Neuroeducation at the university. And so I teach, but also do research predominantly around inequalities. And with that hat, I have had sort of the wonderful fortune of collaborating with Joe. Many of you will be aware that the concept race is long disputed within philosophy, sociology, anthropology, but also within medicine and public health, which is the field that I work in. How do we define race? Is it a concept that we can define physiologically, biologically, genetically? These are the sorts of things that Joe has been working on for a very, very long time, and is one of the few global experts as an evolutionary biologist. We've been working on the first ever textbook on anti-racist medicine, where that background of the historical roots of racism as a race as a concept is feeding into a curriculum that we're designing and developing in terms of whether or not race should be included as part of our diagnostic, management, treatment endeavors in medicine, and also its implications for policy and research. So if any of you want to know more about that project, we'd be very, very happy to tell you more about it. It's wonderful to have an opportunity to come together today. So thank you so much, and thank you to Wharton and to NDPH for bringing about this collaboration. It's timely because the BMJ journals not so long ago, just a few weeks ago, got into a lot of trouble asking their contributors to put race as part of the demographic information that they're collecting. And understandably, there's been a furore on social media where contributors, reviewers have been boycotting this as a process. And although their explanation for why they're collecting this data is to try and address inequalities, the concept of race itself, its historical roots and its origins within colonialism, discrimination, prejudice is something that's incredibly important for us to be mindful of. Given these challenges, how do we think about race and ethnicity, the term predominantly used in the UK, in this context of inequalities? How do we explain patterning of disease and health according to some of these sorts of demographic lines? And I'm posing these questions, and I'm hopeful that these are some of the sorts of things that Joe will be discussing with us this afternoon. The format is a 40-minute formal lecture in this very cool format. And it's on Zoom today, but Joe, maybe in time will be a hologram for us in Oxford. I don't want to spend any more time in this preamble, but I did want to take an opportunity to introduce Joe formally. Professor Joe is the Mackenzie Scott Endowed Professor of Biology at North Carolina A&T State University. His research is predominantly in evolutionary genomics, and he has written and researched extensively on this topic. He's written a plethora of books and papers. Do Google him for the entire list, but there are 3 texts that I did want to share with you. The most recent of which is Racism, Not Race, which I have read and thoroughly recommend. A lot of the questions that I've had in terms of health research policy and practice are answered in that book. But he's also written The Emperor's New Clothes, Biological Theories of Race at the Millennium, The Race Myth, Why We Pretend Race Exists in America. Thank you so much for joining us, Joe. And we're really looking forward to what you have to share with us, and then we'll open up for Q&A with the audience after. Thank you.
Thank you, Marinisha. I am incredibly honored to have been asked to share this time with you and Dr. Shepard today. So you know who I am. So let us begin. So I first began to think about why and how people thought racially in our society in the early 1990s. The Emperor was first published in 2001, The Race Myth coming out 3 years later in 2004. Now, after I wrote The Race Myth, I really thought that I would never have to write another book about race again. And it turns out that I was greatly misled in that assumption when my good colleague, Dr. Alan Goodman, a former president of the American Anthropological Association, called me up in 2019, and he opined that all of the things that we thought we had explained clearly in our previous works were still circulating as violent misconceptions throughout American society. I also argue that it's rife in Europe as well. I remember speaking in Poland in 2017, where they still use the Bloombachian 3-race category in their teaching in secondary school. So this is a problem that exists across the globe, certainly also in the Far East as well. So we put together Racism, Not Race, based upon a series of questions that we had gleaned from educators, policymakers, friends, family, church members. And it's designed to give concise and accessible answers to questions about race and racism. Now, we wrote this book for people who want to work towards human equity, and for readers who are often nervous about saying the wrong thing. And in our country, in many cases, those two groups overlap. Certainly, if you're a white supremacist, Nazi, or Klan member, you're not going to like this book. But the book is based in solid science. So whether you like it or not is really sort of irrelevant. You would have to debunk, the scientific basis of what we say, which I argue you cannot. Now, we found over the course of our careers that there's this ongoing confusion concerning the meaning and significance of human biological variation, particularly in relation to disease predisposition, which is going to be the focus of my talk today. Now, in addition to the book, Racism, Not Race, here are some recent papers that I and my colleagues have published in a variety of venues. Ongoing racial misconceptions with my good colleague, Dr. Andrea Dayrup from Duke University's Department of Pathology in the New England Journal of Medicine. We also collaborated with Lainey Ross, one of the most esteemed pathologists in the United States, for this paper, Race in the Reading, a study of problematic uses of race and ethnicity in a prominent pediatrics textbook, which appeared in Academic Medicine in March of 2022. And I will point out, as a result of this paper, the American Academy of Pediatrics shortly afterwards came out with a statement against racial medicine. And I cannot believe that it was just a coincidence that since we critiqued their textbook in this paper, that a month or two later, they were moved to come out with a statement condemning racial medicine. The myth of the genetically sick African appeared in Genealogy, also in February 2022. And this paper with my colleagues Paula Harvey, Meredith Spence-Bolio, and Angel Bradford, Embedded Racism, a critical but neglected health determinant in evolutionary medicine. This was published in Evolution Medicine and Public Health, which is the flagship journal of the International Society for Evolution Medicine and Public Health, a society that I helped to found. And I also hope to be attending their annual meeting, which this year will be held in Durham, England. So the most relevant chapters in R&R for this group, I think, are chapter 1, setting the table, what is race, racism, and human biological variation. Chapter 3, everything you wanted to know about genetics and race. Chapter 5, why do races differ in disease incidence? And chapter 6, life history, aging, and mortality. Now, I think, there are a lot of other important chapters in the book, so I would encourage you, if you're going to read it, to read the entire thing. But if you just wanted to get after misconceptions that still circulate in biomedical research and clinical practice, these chapters are those which are most relevant. Now, you will often hear in the humanities and the social sciences this statement: race is not a scientific concept. Now, this statement actually fails because it conflates two very different concepts. First, the biological race concept, which has its own history, and the socially constructed and socially defined race concept, which has its own history as well. Now, the two have interacted throughout their existence, so don't get me wrong. It's not as if one can study one without studying the other, but they have two very different intellectual traditions. So with regard to the biological race concept, I published a paper in the proceedings. Actually, it was a Cold Spring Harbor Perspectives in Biology, also in 2023, going through the history of the biological race concept, specifically from the lens of evolutionary biology. Now, this biological race concept actually begins in creationist biology. So most people, when they think of biology, don't think about its history with regard to the fact that in the Western world, it really came into existence in the context of special creationist beliefs about nature. And these early beliefs began to differentiate organisms by their physical appearance or morphology. Now, in the 19th century, still within the context of special creationism, theories of race began to be located around geographical location, and this was mainly the intellectual product of Louis Agassiz, who developed his zones of creation theory, in which he felt that each area of the globe had an act of special creation, of special fauna, special flora, but in particular, an original pair, an original Adam and Eve, which were created at different times in God's creation. And this spawned the concept of the pre-Adamite races. And that meant that only the Europeans were the descendants of the Adam and Eve that are described in Genesis. Whereas the other so-called races of mankind, of humanity, were produced by separate and different and inferior creations by supernatural means. Now, we don't actually begin to get population-based or frequency of gene conceptions of biological race until the 20th century. And I'm going to talk about how this comes about later in this talk. And finally, in the latter portion of the 20th century, phylogenetic tools were used to define cladistic races, which would have to be a unique evolutionary lineage. Now, one of the things I want to point out about the biological race concept, and this should, I hope, be somewhat apparent, is that this was a concept that could be applied to any biological species that had biparental inheritance, not just human beings. Now, in contrast, the socially constructed or socially defined race concept only applies to human beings. And it arbitrarily utilized aspects of morphology, geography, culture, language, religion, but only did so in the service of a specific social dominance hierarchy. That is why Alan and I entitled our last book, Racism, Not Race, to drive home the point that it was the historical processes of colonialism, genocide, and racism that created the conceptions of socially defined races that we live under in the Western world. This was not the result of an objective examination of underlying biological variation and applying some legitimate biological theory to bring these groups into existence. In fact, it little to do with that. Now, it is certainly true that through the interaction of these social definitions and the growth of the fields of biology and anthropology, that the science began to justify the classifications of race that were used in the Western world. Now, okay, I also want to make this last point. Based upon the modern evolutionary criteria for the distinction of or the identification of races, human beings do not have biological races. There are plenty of species that do. We just don't happen to be one of them. Now, this does not mean that human beings do not exhibit geographically based genetic and physical variation, because we do. But that variation isn't sufficient to unambiguously apportion human populations into biological races. And that's the misconception that most people operate under. So now I'm going to give you an example of how social definitions don't really work well if we're interested in biological variation. So these are the Census Bureau categories that are used in the United States at current or the present time. Now, I want to make really clear for those of you in the audience that don't know a lot about American history, and I would argue that you're not alone in this, because Americans don't really know a lot about American history, and that has been a planned program of ignorance, and it's actually getting worse in our country, but that's another topic for another day. Now, those categories have changed throughout different periods in American history, demonstrating their utility for political and social needs, as opposed to something that would be used in biomedical research or clinical practice. So, white, person having origins in any of the original peoples of Europe, the Middle East, or North Africa. But this leaves open the question exactly how much. How much of that ancestry do you have to remain in the white category? Black or African American, a person having origins in any of the Black racial groups of Africa. And once again, we're left with this question: exactly how much of that ancestry makes you Black? And this is particularly important when one considers that there's more genetic variability on the continent of Africa than all of the rest of the world combined. Now, American Indian or Alaska Native, a person having origins in any of the original peoples of North and South America, including Central America, and who maintains tribal affiliation or community attachment. So under this definition, a person who could have lived within those communities, could have been born in those communities, but who suddenly decides, oh, I don't want to be part of the tribe anymore, is no longer counted as an American Indian or Alaska Native. Asian, a person having origins in any of the original peoples of the Far East, Southeast Asia, or the Indian subcontinent. And there's a whole list of countries. And my response to that is really, because this is a huge swath of the geography of the world. And these populations do differ in allele frequencies in ways that are involved in the predisposition of individuals to given disease profiles. So you really can't use this as an effective categorization of people at all. And again, you also have the problem of exactly how much ancestry from these regions keeps you in this category. Native Hawaiian or other Pacific Islander, person having origins in any of the original peoples of Hawaii, Guam, Samoa, or other Pacific Islanders. And once again, we're left with the question, how much of that ancestry allows you to remain in those groups? Now, in the UK, the census categories are based around the concept of ethnicity. Now, in sociology, ethnicity is defined as groups set apart from others because of their national origin or distinctive cultural pattern. So this is really a very different way of categorizing people compared to the way it's done in the United States. Now, the ethnic groups on the census are Asian or Asian British, including Indian, Pakistani, Bangladeshi, Chinese, or any other Asian background. Black, Black British, Caribbean, or African, Caribbean, African, or any other Black, Black British, or Caribbean background. Multiple or multiple ethnic groups, white and Black Caribbean, white and Black African, white and Asian, any other mixed or multiple ethnic background. White, English, Welsh, Scottish, Northern Irish, or British Irish, Gypsy or Irish traveler, Roma, any other white background, and then other ethnic groups such as Arab. Now, it seems that this classification system is an imperfect code for biological race, similar to the American socially defined races, but we shall see whether this makes any sense whatsoever. Now, here is an example of how geographic variation and socially defined groups just don't work well together. If you look at adaptation to malaria, genetically based adaptation to malaria, you will find that it exists wherever malaria is present. And there are different adaptations at different frequencies in different portions of the world's geography. So if we, for example, use the term, Asian, there are some regions of Asia where these adaptations exist because of the high transmission of malaria. But then there are other portions of the continent where it doesn't exist at all. They don't exist at all. But based upon the census definition of Asian, you don't really have a way to separate these groups. For sickle cell HBS allele, it's found in Central Africa, it's found in Western Africa, it's found in Spain, Italy, in the Middle East, in Greece, in portions of Saudi Arabia and Yemen. It's found in India. So you can't use that genetic variant to identify, or it's not unique to any specific ethnic or socially defined racial group. Similarly with thalassemia variants, which are found from Spain all the way into New Guinea and in sub-Saharan Africa. So using these categories doesn't tell us a whole lot about what we can expect with regard to their genetic variability. Now, if we wish to understand the definition of geographical or biological races, you really have to use the tools of the neo-Darwinian synthesis, which was the unification of natural selection with the principles of Mendelian genetics. And this questioned the origin, significance, and maintenance of geographical variation in all species. Now, Ernst Mayr, one of the architects of that synthesis, noted that the term subspecies was equivalent to geographical race and had come into common uses in the 19th century, replacing the notion of the variety, which naturalists like Linnaeus used. And here is what he says about conception. The concept of subspecies is fallacious. Species are not composites of uniform subtypes or subspecies, but consist of an almost infinite number of local populations, each in turn in sexual species consisting of genetically different individuals. The difficulties of the subspecies concept are intensified if one considers the subspecies not merely as a practical device of the taxonomists, but also as a unit of evolution. The better the geographical variation of the species is known, the more difficult it becomes to delimit subspecies, and the more obvious it becomes that many such delimitations are quite arbitrary. Now, in that regard, if we look at the human species and examples of strong adaptation driven by natural selection, for which we have good evidence, you will note that there's really not a lot of traits that fall in that category. And certainly they're not the ones that people tend to want to associate with social definitions of race. Now, of course, some of them are. When we'll take, for example, skin color. Skin color varies from the temperate zones to the tropics in a relatively continuous way. In terms of major genetic variants involved in determining skin color, there are 4 to 5, and maybe another 15 to 20 variants that contribute to variation in skin color. Now, I want you to take into account the fact that the human genome contains on the order of 19,000 protein coding genes. And of those, at most 20 contribute to variation in skin color. So it's an absolutely infinitesimal portion of our genome, but yet in our social history, skin color has been a prominent trait. Similarly, things like adaptation to malaria, things like adaptation to African sleeping sickness, trypanosomiasis. We also see variants associated with lactose persistence. But we see this not just in Europe, but we also see it in the Middle East and in populations in East Africa. Adaptation to high altitude, which we see in the African Rift Plateau. We also see it in the Himalayas. We also see it in the Andes. Now, the genetic variants associated with these traits are different, but adaptation to altitude has occurred across the globe, and so on. And yet, and still, when we consider the traits for which we see strong evidence of adaptation, the vast majority of these are single Mendelian loci. Height, which is polygenic, is seen in Northern Europe, also evidence of this in Central Africa and in the Brazilian rainforest in the form of the rainforest phenotype. And again, one of the traits for which we don't see any evidence of strong adaptation anywhere on the globe is intelligence. And that's something, of course, I would like people to think about when we come back to claims about race throughout the history of science. Now, in the 19th century, the understanding of human races was based in special creations. And at this time, the notion of separate creations or polygenism dominated thinking in the United States and in the United Kingdom. So in 1799, Harvey and Lindsay defined the disease cachexia africana, or dirt eating, which they saw associated with emotional distress and depression. Now, it turns out that dirt eating is behavior that is found in tropical environments and is associated with iron depletion. Tiedemann thought that darker skin allowed Africans to withstand heat and humid conditions better than European. He was right about that. Okay, but that's also true of all people with darker skin, not just Africans. Samuel Cartwright felt that there was a different form of consumption, which we know now to be tuberculosis, that Negro consumption was different from white consumption. He also defined the disease drapetomania, which was the irrational desire of Negroes to run away from slavery. Another one of the diseases he defined in enslaved Africans was dysthesia, a disease that caused enslaved people or slaves to perform tasks in a haphazard manner. Now, Cartwright's cure for these two diseases was simply to treat the slaves in a paternal manner. Now, this stayed with us these kinds of beliefs into the 21st century. In a prominent op-ed in the New York Times published in 2002, Sally Seitel, who was then a member of the American Enterprise Institute and a psychiatrist and lecturer at Yale University School of Medicine, said, "In practicing medicine, I am not colorblind. I always take note of my patient's race. So do many of my colleagues. We do it because certain diseases and treatment responses cluster by ethnicity." Now, of course, you can see the error in her thinking immediately in that she conflates race, which she gives no definition of in her statement, with the idea of ethnicity, which she also gave no definition. Now, in 2016, a paper was published in the Proceedings of the National Academy of Sciences, USA, demonstrating that racist misconceptions were common in students at one of America's most prominent medical schools, the University of Virginia. For example, the belief that Blacks age more slowly than whites. 33.3% of medical students thought that. 38.9% of second-year students believe that. And it only dropped to 23 in the third year of medical school. And 50% of the residents. Now, of course, these residents came from a variety of medical programs around the country, not necessarily UVA, where they were actually attempting to address these misconceptions. Others, and one that was particularly problematic, was the idea that Black nerve endings were less sensitive than whites. That was held by 12.7% of first-year students, 19.4% in second year. Luckily, by the third year, their curriculum had sufficiently addressed that misconception. But again, 14.3% of the residents felt that. Now, we know that because of these false beliefs in the United States, that African American or other dark-skinned patients were less likely to receive pain medication when it was requested compared to socially defined white students. Now, over the last 2 years, I have been giving a series of grand round lectures at leading medical schools in Canada and the United States with my colleague, Dr. Andrea Dara. And we can tell you, based on our interactions with physicians at these schools, that these misconceptions still exist in faculty and in medical students. Now, to undo these misconceptions, we need to be able to address the typological beliefs that are at the foundation of them. Now, one of those is this idea of the genetic distance between Africans and Europeans. And in the United States, particularly African Americans and Europeans. So in the United States, because of the institution of chattel slavery, and we know that most of the European admixture in African Americans occurred during chattel slavery, the average amount of European ancestry that self-identified African American has is about 16%. But that can differ dramatically depending upon the parts of the country. For example, in West Virginia, it's on the order of 30%. In South Carolina, it's closer to 5 to 10%. So the social history of the United States strongly influences the amount of European ancestry that is displayed in people socially defined as African American. Now, this is even more complex when we use the ethnic term Latino or Latin American. Now, in the United States, there are only two ethnic groups: those who speak Spanish, who are called Hispanic, and those who do not speak Spanish, who are non-Hispanic. Now, of course, this has the problem of, ignoring other languages, but people from Latin America represent a triad mixture of European, African, and Amerindian or indigenous ancestry. And this can vary dramatically depending upon which region of the Caribbean or Latin America, those populations originated. For example, in Puerto Rico, which is a U.S. protectorate, the mean ancestry is 72% European, 12% African, and 16% Amerindian. Whereas in Mexico, and Mexican Americans represent the largest group of Hispanics in the United States, their ancestry is only 46% European, 51% Amerindian, and only about 3% African. In Peru, their ancestry is 80% Amerindian, 18% European, and about 2% African. In Colombia, the national averages are 64% European, around 25 to 29% Amerindian, and 7% African. However, within all of these countries, there are people who still are African or Amerindian. For example, in this nation of Colombia, in the regional capital of Medellin, the people there display the national averages with regard to the triad mixture. But in the state of Chocó, which was a center of gold mining, and it saw the importation of large numbers of enslaved Africans, their admixture profile looks very much like that of African Americans, although they have a much larger amount of indigenous ancestry compared to African Americans. Now, when these people come to the United States, they become immediately racialized. So fair-skinned Colombians get called white based upon American social definitions, where on the other hand, dark-skinned Colombians get called black. Now, if you ask these people if they're black, they will look at you like you're crazy. They say, I'm Colombian. And this is, again, because social definitions of race differ in different societies in different historical periods. Now, to make the point as powerfully as I can, humans do not have biological races. Now, why then are there socially defined racial disparities in health and disease? To do that, particularly for the diseases which make up the bulk of health disparity, things like heart disease and cancer, which are complex traits, you have to understand the interaction between genetic sources, environmental sources, gene by environment interaction sources, and the covariance of genes and environment. Also, depending upon how the trait is measured, error terms can make a big contribution to differences that you define or observe between various groups. Now, what I've argued in, a number of papers and books since 1990 is that we see a large difference in health profiles, which result from a small effect from genetic difference, a large effect from environment, a large effect from gene by environment, a large effect by the covariance of genes and environment, and an unknown effect of error depending upon the disease system in question. So below I give examples of the mortality ratio of African Americans to European Americans in heart disease and cancer. So for example, in heart disease, age-specific profiles between 2 and 2.5 times, and this of course only begins to decline at later age. In cancer, again, we see between 1.5 to 1 differences in mortality due to cancer. The dotted line at the bottom is the identity line. In other words, what we would predict if both groups showed the same pattern of age-specific mortality. We also see this in diseases like influenza and septicemia. And again, this cannot be explained by genetic differences between these populations. Now, to make the point powerfully why genetic differences don't explain the differences that we see in health profiles. If you measure potential and probably deleterious genetic variation across European American and African American populations, it turns out that the genetic variants that are possibly deleterious, there's no statistical difference. So on the left-hand side of this panel, the probability value for this test, 0.2. African Americans, European Americans have the same number of homozygous, possibly deleterious variants. However, when you look at those variants that are probably deleterious, it turns out that European Americans have statistically significantly higher amounts of probably deleterious genetic variances across the entire genome. So if one were going to make the argument that genes are driving health disparity differences between African Americans and European Americans, then you would predict that you would have more illness in European Americans and less illness in African Americans. But in fact, we see the exact opposite profile. Now, when we measure how this impacts these groups across time, we can do that by looking at, for example, the heritability of lifespan. Now, heritability in lifespan has been measured in a variety of populations across the globe. Well, some of the highest estimates come from European populations determined by twin studies in Sweden, and you get an H squared of about 0.33, which for a quantitative trait is actually pretty high. Now, if you look at those same estimates of longevity of European Americans in New York City over the 20th century, that heritability was about 0.3, which is close to the highest estimates for this trait that have been found around the world. But for Caribbean Hispanics in New York City, it's only 0.15. For African Americans in New York City, it's only 0.1. And what that means is that for European Americans, their genetic potential for lifespan is contributing about 30% of how long they lived. For Hispanic Americans, it's only 15%. And for African Americans, it was only 10%. Meaning that even though these individuals could have lived longer, other influences, environment, gene by environment, covariance, influenced their shorter lifespans. And again, we have a very large literature supporting the fact that when individuals from the countries that African Americans came from, when they move to the United States within one generation, they take on the health profile of African Americans, a health profile that they did not display in the countries that they came from. So, what are the causes of these disparities? Well, again, there are intrinsic or genetic causes, okay, such as selective advantage in the case of things like sickle cell anemia. There can be founder effect, genetic drift in the case of severe combined immune deficiency in the Jicarilla Apache or Navajo nations, or you can have endogamous inbreeding, which increases deleterious genetic effects in a number of ethnic groups. And this plays the smallest amount of contribution to disparities. Richard Cooper said, the central observations remain. Variation is continuous and discordant with race. Systematic variation according to continent is very limited, and there is no evidence that the units of interest for medical genetics correspond to what we call races. Now, if we look at traits such as early birth, you can see in this data where you're looking at infant mortality for people socially defined as Black in the United States, they have the highest rate, followed by American Indian and Alaska Natives. And once again, if you look at the data to the right, where we look at differing birth weights, and birth weight is strongly correlated with infant mortality amongst US born Blacks, African born Blacks, and US born whites, that US born whites and African born Blacks have the same distribution of birth weights. It is African Americans or US born Blacks who have the distribution to the left, showing lower birth weight and therefore likely to have higher infant mortality. Again, in conjunction with the reports that I showed in the last slide, this indicates that there is an effect of structural racism that African-born Blacks don't experience in the way that African Americans do in the United States. Now, if we look at things like cancer, the colon and rectum, corpus and uterus, again, we see Black males, Black females showing higher rates compared to white men and white females. Okay. Diabetes and hypertension. We see again the disparities with Blacks showing higher hypertension and diabetes. Now, what's wrong with the way this figure was created, and this was done by my colleague, Dr. Dayrup at Duke Pathology, is the scales are different. So if you want to see what the numbers really would look like if they were using the same scale, then you would see this pattern for hypertension in Blacks and diabetes in Blacks compared to whites in the United States. So again, going back to these extrinsic causes, now the extrinsic or environmental causes: poverty, access to care, living conditions, food access, neighborhood, culture, exercise, education, stress, health insurance, individual racism, institutional racism, and systemic racism. And I have argued and demonstrated that these environmental influences are far stronger in determining disparities in the United States by socially defined race than any of the genetic differences. So in our country, people tend to focus on one of the three expressions of racism, and that is individual racism. And they think because, well, you know, I'm not a racist, my friends aren't a racist, that racism doesn't exist. But what they're not thinking about is cultural and systemic racism and institutional racism. For example, there was a time in the United States not too long ago where testing for phenylketonuria was only done in white children. Now, based upon the data that I showed earlier, it is clear that phenylketonuria and other diseases which are endemic in Northern Europeans, things like cystic fibrosis, for example, occur in African Americans through admixture. Also, these diseases exist in all world populations at different frequencies. And you find, for example, for cystic fibrosis, that there are different cystic fibrosis causing variants at different frequencies in different areas of the world. And originally, again, in the United States, the screening for cystic fibrosis only picked up the variants which were of high frequency in Northern European populations and not in the Middle East, not in Africa. And so again, even when screening of people was uniform, the method to screen was in fact biased. So I'm gonna end on this slide and then take questions. So one of the other issues that folks tend not to understand is how most of these complex diseases are revealed by evolutionary mismatch. And what we mean by that is the conditions under which humans evolved in Africa 300,000 years ago are very different than the ones we are experiencing in modern industrialized societies. And to give a sense of what that change looked like, on the slide, I've turned the life of our species into a calendar year. So some of us leave Africa on June 2nd. Some arrive in New Guinea on August 22nd. Some arrive in Europe on September 17th. The Iceman died in the Alps on December 1st. Now, agriculture starts in the Middle East on December 4th. So for most of the time our species existed, we existed on a hunter-gatherer diet. Only within the relative last month of our existence did we have agriculture. Transatlantic slave trade, December 29th in the afternoon. The Industrial Revolution, December 29th in the evening. Cardiovascular disease doesn't become prevalent in world populations until December 30th. Okay. The obesity epidemic or rise in obesity in the United States doesn't happen until December 31st in the afternoon. So anyway, I'm going to stop here and take any questions that the audience might have. And I'm also going to ask folks who are online, if you are not speaking, please mute yourself.
Thank you so much, Joe. I mean, that was incredibly comprehensive coverage of your work, demystifying the biological basis of race, but then also leading us very helpfully into this incredibly complex terrain of how diseases practice and how it is we may understand the reason for some of those inequalities. I'm going to throw it open to the room. Who wants to kick us off in terms of questions? Yes.
Thanks, Monisha. Thanks, Professor Graves. That was wonderful. I feel like I learned a lot. I was wondering if we're hoping to kind of move forward and combat these disparities in health, is it still useful to have be trying to address health disparities along the lines of experiences of racism, or does that kind of still embed the harms of that racism? And should we be looking directly at those environmental determinants that you were talking about, like poverty, like inadequate housing, all kinds of experiences of disadvantage?
So socially defined race is a legitimate sociological variable. You should also be looking at the direct social determinants of health. So it's not mutually exclusive. Yeah, and particularly in my country, you're not making people any more racist than they are by talking about socially defined race. In fact, the political program of white supremacy in the United States is trying to silence discussions of race, of socially defined race, historically and in its contemporary form. The state of Florida has removed sociology from the core curriculum of its state universities. Precisely so, we cannot have that conversation about the social determinants of health associated with socially defined race. So the important thing that I try to get across to people is that socially defined race is a sociological variable. It is not the same as biological variation in humans. Humans do not have biological races. Okay, we don't. We do have socially defined races that in some way mirror past ancestry, but you can't study health disparity biomedically if you're using this flawed category. Now, to further support what I'm saying, the National Academy of Sciences, Engineering, and Medicine in the United States in March of 2023 just released a report called Population Descriptors in Genomics and Genetics Research. I wrote a report about the report for Nature Behavioral Genetics, which came out a few weeks ago. But what that report basically said was, and they didn't go as far as they should have, and they didn't say humans don't have biological races, but they did point out that socially defined races and human biological variation weren't the same thing. And they called for researchers and reviewers of grants and research manuscripts to have a more stringent examination of the populations that are described in the studies that are being done. In other words, who are these people? Where did you sample them from? And to give as precise a description as you possibly could. And so I think that that's what's required in biomedical research, is this precision, which has not been present in the past.
Joe, I'm just going to step in. I feel like everybody's being too polite and convivial, and I want to shake things up a little bit. Let's just build on that a little bit. I mean, some funders, some research organizations, journals even, are challenging what you've just said, and they've said, given the history of race as a concept and its implications of racism, let's do away with these categories altogether. Let's practice colorblind medicine. Let's stop collecting race and ethnicity data because it's meaningless at best and harmful at worst. What would your response be to that type of critique?
James Baldwin said that nothing can be changed unless it's faced, right? And if you're unwilling to talk about it, then you can't change it. Socially defined race is real, okay? And literally what I say it's real as a heart attack, because it has health implications for people in racialized societies. So to say that, oh, we can't collect data by socially defined race, or we can't talk about how racism impacts health outcomes, to me is nonsense, and it's harmful. So that perspective is absolutely wrong. At the same time, there needs to be a growing understanding of the weakness of socially defined categories as predictors of underlying genetic variation. So it's not mutually exclusive. You can and should be examining socially defined populations because they experience societies differently based upon power dynamics. For example, I don't hear anybody saying, we shouldn't collect data on women and men. Okay, women face society differently. And as a result, some of their health outcomes are different based upon patriarchy and institutional sexism. The same thing is true of socially defined race and ethnicity. People experience society differently. In the United States, the biggest predictor of whether you live within 1 kilometer of a toxic waste site is not class. It's socially defined race. So if we weren't collecting data on socially defined race, we would think, oh, it's only class that determines whether you are within 1 mile of a toxic waste dump. But it's not. Okay. In our society, race and class have always had their own dynamics. And you need to be able to understand that. So people are saying don't collect data on socially defined race. I say that's nonsense. That's aid to maintaining white supremacy.
Thank you so much. I mean, it's really helpful, really clear, and you preempted sort of my second potential rebuttal, which is, is race simply a proxy for poverty and some of the other determinants? But what you've really helpfully done is disentangle the two and help us to recognize that it's important that we look at both of those. Question.
Thank you so much for this talk. I guess as a follow-up question, my question is, do you then imagine a world where we can sort of stop doing surveys or accounting for race? Like imagine in a real sense, a post-racial society where we actually address the racial inequalities in health and in environment and do away with race, because I think, although we have certain social constructs that have been undergirded in society, you know, in terms of sex, gender. Race is a relatively new social construction, maybe like the past 1,000 years, maybe. So I wonder if there's a way, just as we think of a society that for so many years, for hundreds of thousands of years, race did not exist as a social construction. Can we kind of reverse the existence through addressing these health inequalities?
So I don't know if you guys can see this.
Yeah, we can see it.
Last chapter of the book is entitled Two Paths, Choosing Up Sides or Joining Hands. In it, I talk about what it would actually take to become a post-racial society. Now, this book was written back in 2004. In the United States, this country has done everything that I told them not to do. So for the last 20 years, it has been reifying and reinforcing white supremacy. So in our country, the notion of a, heading towards that post-racial society, which, I'm a firm believer of, that's, what King talked about, going up to the mountaintop. I would like to make it to that mountaintop, but I now know I will be long dead and gone before that can happen. So the question that you have to ask yourselves is, what are you willing to do to create a post-racial society? And, I really bless my colleague Marnisha for having asked me to participate in the writing of this book for Elsevier, Anti-Racist Medicine. Because it's not enough not to be a racist. You have to take an active anti-racist stance. If you want to live in a post-racial society, get up out of those chairs and do what you have to do to make that happen. Unfortunately, on my side of the ocean, as I said, we're headed the wrong way. Maybe you in the United Kingdom have the opportunity to show us what a post-racial society should look like. But it's not going to happen just because people wish it to happen. It's going to require you changing your disciplines, bringing these issues to the light, and forcing your society to live up to its creed. If you don't do that, you might end up like us on this side of the Atlantic.
So no pressure, Joe.
I mean, I see no alternative. Okay, it's either, we move towards anti-racism, or we will have a barbarous world. You can see it happening all around you. Okay, literally, I could not believe what I am seeing in the Gaza Strip right now. That is barbarism. And I'm not saying that, Hamas doesn't bear some responsibility for what happened there. But this level of barbarism is exactly what you expect in a world that's organized around, race and racial hierarchy. So again, it comes down to what kind of world do you want to live in? I hate to say that my generation has failed. We have failed with regard to pushing forward an anti-racist agenda. I'm speaking to the young folks in the audience. You have an opportunity to establish one, but it really comes down to what are you willing to do? Because it's not going to happen on its own.
Very stirring call to action, Joe.
Well, I have a question, Joe. It feels to me like America has a particularly bad case of this problem, if you like, but I'm not sure even how true that is empirically. But my question to you is, are there any countries that you think are doing a good job, that are a sort of good model for the way forward?
I'm not sure. I'm seriously not sure that I see a model across the globe. So one of the things about the United States, because it has been dealing with racism so long, in many ways, its thinking about how to do anti-racism is advanced. And I say this because I have, been able to lecture in Europe, and I've talked to European colleagues, and their formulations are often somewhat backwards. And Eastern Europe, it's particularly backwards. Same time, because they don't have large numbers of people from different sections of the world, they haven't really been called to task in the way the United States did, because of the massive importation of persons of African descent and the indigenous population that was living here, which this, government attempted to exterminate. The United States is guilty of genocide with regard to its indigenous population. Now, that's not a popular thing to say over here, and you will never hear this government admit to its crimes, either with regard to the way it treated American Indians or the way it has treated its persons of African descent who it enslaved and still has not paid reparations to in any form. So if there's an international model, I haven't seen it. So this, of course, gives you the opportunity to be the first, because somebody is either going to do it, or as I predicted in my last book, Voice in the Wilderness, if we do not solve racism, we will go extinct. That is something that I predict forcefully. If we do not solve racism, we will go extinct.
It's in response to Paula's point. I mean, I'm certainly not an expert in this, but we're learning through the textbook project from colleagues from, for example, New Zealand, that there seems to be a considerable national effort to try and understand the historical implications of colonialism there, as well as racism and prejudice. So there may be green shoots in parts of the world that we may not be as familiar with. But Joe, I think you're absolutely right in saying that there is a lot of work that needs to be done in this space. Just in terms of this sort of discussion debate that's been happening at the BMJ, colleagues from New Zealand in particular have been calling for reform in terms of the terminology that's been used, and really breaking consensus on this. So yeah, hopefully there are some positive signs in different parts of the globe. Any other questions? Yeah, at the front.
Yeah, thank you. Thank you so much for this talk, which has been really thought-provoking for me. I come from a sort of social sciences background, from social anthropology, and in many ways, many of the things that you've been explaining, I think, sit very comfortably with our discipline, which has its own historical challenges, shall we say. But just listening to you at the end and thinking about, well, what would it take to reach a kind of post-racial world? One of the things that strikes me that when you sit in the social sciences is the sort of hierarchies of knowledge that exist, and particularly in that space that involves, health, where sort of social sciences work often seems like sort of nice to have, but it's not really essential to solving, the problem of cancer. And I sort of wonder whether part of that world that we would have to envisage would be to rethink the sort of hierarchies and authoritative types of knowledge and how they relate to other forms of knowledge making in the world. I was just wondering.
To answer your question quickly, I think it's not so much about knowledge making, but about which knowledge you want to deploy for what purposes. So in a paper I wrote, back in 2000 called Against Racial Medicine, it comes down to how one wants to solve a disease like cancer. Do you want to put billions of dollars in biomedical research, developing specific, say, personalized treatment plans, which, you know, can control or expand the lifespan of an individual for a given, a neoplasm, but that's only affordable by people who have really good jobs and really excellent insurance. So that, you know, I was on a panel once with an oncologist from Duke, and I just turned to her and I said, well, how much does that treatment cost? And she said, oh, it's, you know, it's a little over $1 million a year. I'm like, WTF? Who's going to be able to afford that? How many lives are you going to save with all of the billions of research that went into these treatments that's going to cost people $1 million, $5 million a year? How many lives are you going to save? If you gave me equivalent sums of money so that I could build an efficient fresh food distribution network in poor neighborhoods in North Carolina, I guarantee I'll save more lives from cancer than your miracle personalized drug ever will. And it comes down to, you know, who do you want to empower? Do you want to empower the multinational pharmaceutical corporations? And by the way, I work with some of these people, so I'm not completely, you know, free from guilt there. But do you want to empower those people so that they can make mega billions of profit, or do you want to empower poor people so that they can have healthy lives and get control over their neighborhoods? And that's really what this comes down to. It's not that the science is wrong. I mean, don't get me wrong. It's you know, I do genomics research. It's intellectually engaging. You know, it's, you know, the discoveries are really cool, but it really comes down to, what are you trying to do? If you want to, you know, change the health profile in the United States by race, and I was asked on a panel on the New England Journal of Medicine. They asked me, Dr. Graves, at the end, you know, how would you solve health disparity? I had 2 words: universal healthcare. It's really that simple, which, you know, we don't have in the United States. So it comes down to, who are you trying to empower? What are you trying to achieve? The knowledge of the social sciences is just as good as the knowledge of genomics, but it's a question of what the society wants to achieve with that knowledge.
Thank you for the talk, Joe. Really insightful. I have a question a little less related to the discussion, more to your career. I'm wondering if you could share some insights into your personal experiences, both as the first Black person to earn a PhD in evolutionary biology, and also related to your faith in the Episcopalian Church. What was that like, negotiating what can be quite, as you've referenced, a politically controversial field to some people, with those 2 things in mind?
Okay, so I'm hope I'm hearing your question properly. So I grew up in a National Baptist Convention home, meaning on Sundays, I heard the sermons of the Reverend Martin Luther King on a regular basis. It was foundational in my identity, and particularly in my commitment to social justice. But same time, you know, I was interested in studying science, particularly evolution. Most of those churches, okay, are adamantly against the science that I pursued as a career. Now, the way that I managed to integrate the 2 was to change my denomination. I'm now a confirmed Episcopalian. I work with the Episcopal Diocese of North Carolina. That's your Anglican church that quit because we couldn't, you know, have King George as the head of our church because we had this thing called the American Revolution. So, but we also changed our theology over the separation from the Anglicans in a number of ways. But I joined a church where science and faith were not at odds with each other. So now I, work with the diocese. I work with religious communities. I teach science, and I'm somewhat successful in being able to help people stop the war between their faith and their science. I don't know if that answered your question.
Hi, Jerry, thank you so much for your talk. I had a question because I am now sort of, I have a mixed background with social sciences and medicine, and I think these conversations are quite well concerned, like within the social sciences and within anthropology. But I was wondering how you think it's best to start bridging the gap between the social sciences and medicine, because as I return to medicine in my final year, I often have these conversations with doctors and medical students, and they're really receptive. But I think, as you said, it's not enough to just sort of have a passive stance and not be racist. But how do we start becoming actively anti-racist within medical practices and for doctors, for future doctors?
So it really comes down to the social dynamics of your country. Now, in the United States, we have a really big problem with regard to doing anything progressive in medicine, and that's the American Medical Association. Their main focus tends to be the well-being and financial well-being of doctors, as opposed to the health care of people who need their services. So one of the things that the American Medical Association does is it has unnecessary criteria for admitting students into medical training. So they keep their numbers artificially low, so that there are large sectors of our country where there aren't enough physicians for the need, particularly in Black and brown and poor communities. And by doing this, they maintain, the demand part, which allows them to command really high salaries. Now, if I were in charge of the country, I would say this stuff's got to go. We need to train the number of physicians that meet the demand for people having adequate health care. And that means maybe some of your salaries might come down. But that's what the nation needs. We need enough doctors, particularly from those underserved communities, who are willing to work in those underserved communities. Okay, that's what we need. Now, again, I can't speak to the situation in the UK. And by the way, doing that would also require a change in the curriculum. And again, medical associations are really hesitant to address their sacred cow, their curriculum, because they figure they know it all. And we're teaching physicians what they need to know. And when I look at their curriculum, I say, no, you're not. Because there are whole areas that you're not addressing that would make them better physicians and improve patient treatment. So that's a battle that you have to have with your medical associations with regard to, what are you really doing? Are you doing this to keep yourselves in lucrative, high-paying positions, or are you doing this to provide the health care that the nation needs? And somebody has to be willing to have that conversation. The United States, we are, when it comes to these things, we're spineless. I'll say it to their faces, but they're not going to listen to me.
Slightly different routes to the problem here, Joe. I mean, I don't think with all of the strikes and challenges around junior doctor contracts and how little they're being paid, that's the issue. But certainly what resonates is that we don't have a large enough and sustainable workforce and not a diverse enough workforce. So I think there are some similarities, but also differences in what's happening across the pond.
So why is it so hard? Why, if you think you can, like you said earlier, convert all that funding that goes into pharma into better ways to get value for money and improve people's health, or similarly, why, just getting new things into the curriculum? Why is the pushback so difficult? When I teach evolutionary medicine, but I teach it to anthropologists, not to medical students, except for a few that come here. Why is there so much resistance?
Well, I mean, the one time I taught evolutionary medicine in a medical school, you know, they came to the first couple of lectures, and I'm talking about the physicians, not the students. And the students had to come because it was required of them. But, you know, the physicians just stopped coming because they weren't interested. So why the pushback? I mean, I would argue that there is a unholy marriage between and again, I'm speaking in the United States. I can't speak to the same thing in the UK. In the United States, there's an unholy marriage between the pharmaceutical industry and the medical profession. Because what pharma wants to do is to have doctors prescribe their medicines. And if you had the opportunity to look at television in the United States, virtually every television program that you see on networks where there's advertising is consistently some new drug to treat some chronic condition. Now, why? Because there's a lot of money in a chronic drug that treats a condition that a patient never gets cured from. Okay, whereas the same industry isn't working to produce new antibiotics, right? Because antibiotics, you use them and the condition's gone. So with this unholy relationship between medicine and pharma, unless you can break that, unless you can have a society understand that it's literally killing itself in the long run by maintaining the power of these industries over our society, that's not going to change. They're not interested in evolutionary medicine because our approach vitiates what they're doing. You're not going to invite the person to dinner who can demonstrate to you that everything you're doing is absolutely wrong and harmful. You're just not going to do that. So again, it doesn't come down to the power of the science per se, because I think our perspective clearly is scientifically correct. It comes down to who benefits from which scientific paradigm you operate under. Big pharma makes billions of dollars from the current medical paradigm, and they're not going to give that up easy.
Questions, anybody else on this?
Hello, thank you very much for your talk. So I was thinking, obviously you mentioned some of the problems with using racial categories as, well, as a poor allegedly for geographically distributed disease-linked allele frequencies. My question is, how naive is it to think that with some of the advances in affordable genome sequencing, will that be a force for promoting more equality in healthcare?
I mean, it could be. Now, other more simpler things with regard to, you know, the difference between populations and families, right? Diseases run in families. They may be at different frequencies in different populations, but at the end of the day, it comes down to whether your family has this disease. For example, my grandfather died of prostate cancer. My father was treated for prostate cancer. Highly likely that I'm going to develop prostate cancer. Now, I don't know that because I'm African American. I know that because my grandfather died from prostate cancer. My father had prostate cancer. Good chance that I had prostate cancer. My mother died from congestive heart failure. My father had congestive heart failure problems. Good chance that I'm going to at some point develop congestive heart problems. You don't need to know anything about population to be able to address those. You don't have to sequence my genome. You don't have to do 23andMe and find the risk markers in my genome for $1,000 when just asking, you know, a patient, what conditions are in your family? And you could use sequencing to, in some cases, you know, to, what's the word, confirm that if you had to. So again, there are a lot of low-cost, non-high-tech methods you can use in diagnostics with patients that are currently not being used. Now, I know this again because I work closely with the pathologists at Duke Hospital. And she can tell me, has told me that doctors don't do this during their interview. And again, when asked, why don't doctors do that during the interview? It's because they have 30 minutes with the patient. And they use the algorithm they've been given in the 30 minutes. So again, what are we doing here? Why do our physicians only have 30 minutes with a patient? It seems to me that that's not a necessary condition. It happens because our healthcare system runs for profit. That's why you have 30 minutes with the patient.
Thank you so much, and thanks for this extended, not so very female, Q&A. This has been really great. Thank you all for coming. I'm going to switch this off now, but it'd be nice to carry on the discussion at the back there and have a little pre-dinner drink. But thank you. Let's give a great round of applause.
And again, thank you all for inviting me.